we will be studying about anatomic landmarks. The knowledge of anatomic landmarks is important for impression making and denture construction. Why is it so? Because the edentulous ridge, all areas are different. Some areas have the capacity to withstand loads more than the others. So when we make the impression, we would apply more load on the areas which are capable of withstanding the stress of mastication, and we will not apply stress to those areas uh, which are not capable of withstanding such loads, because if we apply stress on those areas, they will eventually resorb. So this is the significance of knowledge of anatomic landmarks and the impression making via selective pressure technique. So there are three theories of impression making: mucostatic, mucocompressive, and selective pressure. We'll be studying those in next videos. So let's begin with the anatomic landmarks. So, Boucher has divided the basal seat area and as well as surrounding areas into four categories: primary stress bearing areas. These are the areas which have the capacity to withstand masticatory loads without undergoing resorption. And secondary stress bearing areas. These are the areas which tend to resorb under load. Note that primary stress bearing areas have the capacity to withstand masticatory loads, while secondary stress bearing areas, they tend to resorb under load. Then there are the limiting areas. These are the areas to which maximum extension should be done in comfort and functional limits of surrounding muscles and tissues. We'll be studying all these in detail in the video. So relief areas, these are the areas which require relief. If we do not provide relief, they will eventually resorb. So this is just the outline of what we'll be studying in next two videos of the anatomic landmarks of maxilla and mandible. So in maxilla, the primary stress bearing areas are hard palate and maxillary tuberosity. Secondary stress bearing areas for maxilla are crest of ridge and rugae. Limiting areas are labial frenum, labial vestibule, buccal frenum, buccal vestibule, hamular notch, Ppsa, posterior palatal seal area or postdam, Phobia, Palatine. Relief areas for maxilla would be incisive papilla, mid-palatine raphe, torus palatinus, and canine eminence. And for mandible, whenever you start a chapter, just make this outline. It will be very easy to grasp the whole chapter if you do so. So just make the outline in the beginning. So I'll be providing outline for all the chapters. So for mandible, the primary stress bearing areas are buccal shelf area and retromolar pads. Secondary stress bearing areas are slopes of alveolar ridge. Limiting areas are labial frenum, labial vestibule, buccal frenum, buccal vestibule, lingual frenum, alveolo-lingual sulcus, pterygomandibular raphe, mental foramen. So relief areas are mental foramen, genial tubercles, torus mandibularis, and mylohyoid ridge. In exams, they ask you biological consideration in mandibular edentulous impression. In that, you will have to write about the anatomic landmarks of mandible. So let's begin with the anatomic landmarks of maxilla. So let's begin with the landmarks of maxilla. Maxillary denture bearing area is more than that of mandible and is 24 centimeter square, while that of mandible it is 14 centimeter square. Supporting structures, these are the load bearing areas. They show minimum resorption under constant load. So denture should be designed such that most of the load is concentrated here, because they are capable of withstanding the forces. So we will try to concentrate most of the load in the supporting structures. So supporting structures or stress bearing areas. So the primary stress bearing areas, these areas have thick mucosa and are made of cortical bone and are perpendicular to the occlusal forces. Primary stress bearing areas, as we already studied in the outline, for maxilla, primary stress bearing areas are hard palate and maxillary tuberosity. So what makes hard palate a primary stress bearing area? So we'll study a little bit about how hard palate is formed. Anterior part is formed by the palatine processes of two maxilla. Maxilla is a bone. These are two bones in our skull. So these have four processes. Out of the four processes, the palatine process, two palatine processes form the anterior part, which join at the median suture, while posterior part of the palate is formed by the horizontal plates of the palatine bone. Horizontal plates of the palatine bone and the palatal process of the maxilla. So, trabecular pattern of bone is perpendicular to the direction of force in horizontal portion of the palate, lateral to midline, making the latter capable of withstanding any amount of force with minimum resorption. Bone, because bone takes all the forces. This is the mid-palatine suture. This is the relief area. This is the primary stress bearing area, which is the hard palate, and here we can here the maxillary tuberosity is there, which is also a primary stress bearing area. This is a rugae, which is a secondary stress bearing area, and I'm sure you can get better diagrams on the books. So this was about hard palate. Now let's see what is maxillary tuberosity. Maxillary tuberosity, it is a bulbous extension of residual ridge in second and third molar region. Posterior part of ridge and tuberosity areas is one of the most important areas of support because they are less likely to resorb. Why is it a supporting area? Because least it is least capable of it is most capable of withstanding the stress and least likely to resorb. So gross enlargement of the tuberosity, it can be fibrous, collagen fibrous or bony. Gross enlargement of the tuberosity requires surgical correction. If one tuberosity is enlarged, it can be retained. However, if both are enlarged, it would require a surgical correction. If one tuberosity is enlarged, it will help in retention of the denture. Distal end of the denture must have coverage, that is stability. So, secondary stress bearing areas for maxilla. It is the crest of the alveolar ridge. According to GPT Glossary of Prosthodontic Terms, it is defined as that portion of alveolar ridge and its soft tissue covering. So, this is the portion of the alveolar ridge. Alveolar ridge is the one which supports the teeth. Alveolar ridge and its soft tissue covering, which remains following the removal of the teeth. So, when the teeth are extracted or removed, the portion of the ridge is known as the residual alveolar ridge. So the crest of that ridge is the secondary stress bearing area for maxilla. And rugae are the mucosal folds located in anterior region of palate radiating from the median suture. We studied about the development of palates. We saw the anterior part is formed by the palatine process of maxilla fusing in the midline. If this is the midline, they fuse in the midline at the median suture. So these rugae are the mucosal folds which are located in the anterior region and radiate from the median suture. Refer the book for diagrams. I'm very bad at making diagrams. So rugae, these are the folds of mucosa which play an important role in speech as well. So, limiting structures of maxilla. They determine and confine the extent of denture and form its boundary. Hence, they provide retention to the denture through seal against entry of air as well as food. So, labial frenum. It is a fold of mucous membrane. Okay? It starts superiorly from the inner surface of lip in a fan-shaped manner and attaches to the labial side of the ridge. So, if this is the lip everted and this is the ridge and these are the maxillary incisors, so from the inner surface of lip, it starts superiorly from the inner surface of lip in a fan shaped manner and attaches to the labial side of the ridge. This is the labial side of the ridge, and towards the palatal aspect of this teeth, there will be the palatal aspect of the ridge. So it starts superiorly from inner surface of the lip in a fan shaped manner and attaches to the labial side of the ridge. So this frenum, it has no muscle and hence no action of its own, therefore it is a passive frenum. since it does not have any muscle, it is a passive frenum. While as in mandible, the labial frenum, it is an active frenum because it has muscle attachments, which we will study. In the impression, it is recorded as a V-shaped notch. Action of lip in this area is vertical, so labial notch. What is a labial notch? It is the labial frenum, which is recorded in the impression and made in the denture. So it is vertical, so labial notch, yeah, impression V-shaped, it should be narrow. So labial notch should be narrow. Labial notch should be narrow and deep enough to allow the frenum to pass through. So this was about the labial frenum. In case of residual ridge resorption, so if this is the height of the ridge, okay, and this is the frenum attachment, and after some time, when the teeth are lost, the ridge continues to resorb. We studied about the residual ridge, so this ridge will resorb eventually, and the frenum which was attached here, it will be now located towards the crest of the ridge, and in these cases we would require vestibuloplasty. This is just, if you are in a final year student, you will know what is a vestibuloplasty. So in case of ridge resorption, the frenum will be attached at the crest of the ridge, which would require vestibuloplasty, that is deepening of the vestibule. So I know this is not an edentulous cast, but just for the sake of understanding, this is the labial frenum. Can you see it? I don't know. So this is the labial frenum, and somewhat here we will find two folds of mucous membrane, which are the buccal frenum, and between labial frenum and buccal frenum, this valley like sulcus, this is known as labial vestibule, and then from the buccal frenum towards this end, this is the buccal vestibule. So labial frenum, labial vestibule, buccal frenum, buccal vestibule, same on the other side. So coming on to the buccal frenum, we already saw where it is. It is a single or double fold of mucous membrane which divides the labial and buccal vestibule. Okay, we saw in the cast what this line is saying. It is recorded in the impression as buccal notch, like labial frenum was recorded as labial notch. This frenum is recorded as buccal notch, and this is crescent shaped. That one was fan shaped, which is properly relieved and molded to allow muscle activity. This has to be recorded in the functional form, and in case of resorption of this area, we need to relieve it. In labial frenum, there was no muscle attachment, but in mandibular labial frenum, there will be muscle attachments, and that one is an active frenum. So, in labial frenum of maxilla, there is no muscle attachment, while in buccal frenum of maxilla, there are muscle attachments. Therefore, it is wider and shallower. The muscles attached are levator anguli oris, which attaches beneath the frenum, orbicularis oris, which pulls the frenum in forward direction, and buccinator, which pulls the frenum in backward direction. This one is the orbicularis oris, levator anguli oris, and buccinator. So what is the significance of buccal frenum? Buccal frenum, it should be recorded as buccal notch in the impression in functional form. It has to be recorded in functional form. If it is not done, there will be dysfunction of denture during the functioning of the mouth. All this is done by border molding, which will be taken up in the coming videos. So we studied about labial frenum, labial vestibule. Now coming on the labial frenum and buccal frenum. Now we'll study about the labial vestibule. Labial vestibule, it is located from one buccal frenum to other buccal frenum, as we saw in the cast. According to GPT, it is defined as that portion of oral cavity which is bound on one side by teeth, gingiva, and alveolar ridge. In edentulous, it is called as residual ridge. So alveolar ridge in edentulous mouth is known as residual ridge because it is the ridge which is there after the removal of the teeth, and on one side it is bound by teeth, gingiva, and alveolar ridge, and on other side it is bound by the lips and cheek. So what is the significance of labial vestibule? It provides valve seal, accommodates labial flange of denture, and affects appearance of patient. Labial vestibule, in like we saw in the labial frenum and buccal frenum, they are recorded as notch, while as vestibule it is recorded as flange in the impression and the denture. So this one, it will affect the appearance of the patient if it is too bulky, or if it is not, so if it is not of the proper thickness. So all these will affect the aesthetics of the patient. It is divided into two compartments by labial frenum. Like if this is the labial frenum and this is the buccal frenum, one or two folds, buccal frenum, labial frenum. So this is the labial vestibule, and buccal vestibule. So it is divided into two compartments by labial frenum. Labial vestibule is divided into two compartments by labial vestibule. Vestibule is a depression. Intraorally हम क्या बोलते हैं? We call it as vestibule, and it is a depression, while on the cast it is this depression is known as sulcus. On the cast this depression is known as sulcus, while on the impression this is an elevation and it is known as flange. So intraorally vestibule, intraorally this area is known as vestibule and is a depression. In the cast, this area is a sulcus and is a depression. When we make the impression, this area becomes an elevation. Why? Because impression is the negative likeness of an object, and this elevation is then known as flange. And since it affects the appearance of the patient, seal, and therefore we have to record adequate depth and width of this labial vestibule. What happens if we don't record the adequate depth of the vestibule? If overextension, if we overextend the flange, it will cause instability and impinging and soreness. It's common sense. If it overextends in the vestibule, it will impinge the mucosa and therefore cause instability and soreness. And if it is underextended, there will be no proper seal. So proper contouring gives optimal aesthetics. The labial and buccal borders of the denture are not important for border seal because the lips and cheeks create the facial seal. The lips and the cheek, they create the facial seal, so they are not as important as the posterior parietal seal area for creating the seal. Now coming on to the buccal vestibule. Buccal vestibule, it extends from the buccal frenum to the hamular notch, as we saw. So if this was the labial frenum, this was the labial vestibule, these are the buccal frenum, and this is the buccal vestibule. So buccal vestibule, it extends from buccal frenum. If this is the buccal frenum and this is the hamular notch, so it extends from buccal frenum to the hamular notch. It provides good peripheral seal. It extends from buccal frenum anteriorly to hamular notch posteriorly. Buccal flange of the denture is accommodated by the denture. It has to be recorded in the adequate depth and width, and improper extension causes instability and soreness. Size of the buccal vestibule varies with contraction of buccinator. Position. Now this is important. So size of the buccal vestibule, it can be varied according to the it varies according to the contraction of the buccinator, position of mandible, and amount of bone loss in maxilla. As we saw, the size of the buccal vestibule is variable. So buccal vestibule, during examination, buccal vestibule should be examined with mouth as close as possible, because to prevent the coronoid process impeding the space. So buccal vestibule should be examined with mouth as close as possible, because its extent can be deceiving because of the coronoid process obstruction. If mouth is opened wide, so coronoid process will obstruct the space, and then the size of the vestibule will be deceiving. Therefore, while examining the buccal vestibule, the mouth should be as close as possible. The ramus and coronoid process of the mandible and masseter modify the size of the vestibule during mouth opening. Therefore, mouth should be as close as possible. Distal end of the buccal flange should be adjusted in such a way that there is no interference to the coronoid process during mouth opening. This is the significance of recording the buccal vestibule. This should be kept in mind, that the distal end of the flange should be adjusted in such a way that there is no interference to the coronoid process. Now coming on to the hamular notch. Hamular notch, we saw that the buccal vestibule extends anteriorly from buccal frenum and posteriorly to the hamular notch. So now we'll study what hamular notch exactly is. So hamular notch, it is a depression. Depression matlab it will be situated in between two in entities. So it is a depression which is situated in between the maxillary tuberosity and hamulus of medial pterygoid plate. We have studied in anatomy about the medial and the lateral pterygoid plate. So the hamulus of the medial pterygoid plate and the maxillary tuberosity, these contain a depression which is the hamular notch. You can see in the diagram, refer to the book for the diagram. And this is palpated by mouth mirror or T-shaped burnisher. Hamular notch aids in locating Ppsa, posterior palatal seal area. Distolateral border of the denture rests in the hamular notch. So the distolateral border of the denture should rest in the hamular notch. If it rests anteriorly, there will be no retention. It's a common sense. If the denture extends to the depression, there will be obviously retention. So distolateral border of denture rests in the hamular notch. If the border is located anteriorly near maxillary tuberosity, denture will not have retentive properties because border seal is absent when placed over a non-resilient structure. Significance: denture border should extend to the hamular notch. So if the denture border is placed anteriorly, there will be no retention. If it is placed posteriorly, there will be gagging. So gagging matlab vomiting ka sensation. Denture border should extend to the hamular notch, beyond which there will be gagging. And so let's come on to the Ppsa. Very important, can be asked as a short note, and its recording is asked as a long note. We'll study it in coming videos. So posterior palatal seal area, also known as post dam. It is located from one hamular notch to other across the palate, and see, it is located from one hamular notch to another hamular notch across the palate. It is a soft tissue at or along the junction of hard and soft palate, on which pressure within physiologic limits of tissue can be applied by denture to aid in its retention, the retention of the denture according to GPG. This is the definition. I will explain it in coming videos to make this video a shorter one. So it is always located on soft palate between anterior and posterior vibrating lines. Ppsa lies on the soft palate. Anterior vibrating line, it is curved because of posterior nasal spine. So this is the anterior vibrating line which is curved. Why is it curved? Because of the posterior nasal spine, and posterior vibrating line, this will be straight. So this area contacts the posterior surface of the denture base. What are the functions? Coming on to the functions of Ppsa. First and the most important, it prevents air entry and food accumulation between soft palate and denture base. So we have the soft palate, and then there will be our denture base. So this Ppsa is recording. It will prevent air entry and food accumulation. If air enters or food is accumulated in between the denture and the soft tissue, there will be obviously no retention. The denture will fall off. So this prevents air entry and food accumulation, and then it aids in retention by making constant contact with the soft palate during speech, mastication, and deglutition. And it compensates for polymerization shrinkage. So Ppsa compensates for polymerization shrinkage. We know because when we record the Ppsa, it will be an elevation, and then Ppsa reduces tendency of gag. matlab vomiting sensation. Gag reflex, as it prevents formation of gap between the denture base and soft palate during functional movement. Since see, PPSA, it prevents the formation of gap between the denture base and the soft palate. So it prevents the formation of gap. Therefore, there will be no air entry, food accumulation, and there will be retention. And since it prevents the formation of gap, there will be no tendency of gagging. How gagging occurs? Gag is prevented by merging posterior line with the tissues so that tongue doesn't feel anything foreign. Gag कब होता है? जब tongue को कुछ foreign feel होता है mouth में. So this is prevented by the PPSA, or by gag can also be prevented. It is a clinical tip. So if a patient comes to you with excessive gagging, you can either distract the patient or use proton pump inhibitors. So this was about PPSA. We'll study about PPSA in detail in coming videos. So coming on to the next and the final limiting structure, which is fovea palatine. These are two small indentations found in the posterior part of the palate near midline, and they are formed by the coalescence of the ducts of the several mucous glands. These are the glandular openings of the minor salivary ducts. Position of fovea palatine influences the position of the posterior border of denture. So the posterior border of denture should extend 1 to 2 mm beyond the fovea. Secretion of fovea, since it is the glandular opening of the minor salivary gland, so secretion of the fovea spreads as thin film on the denture, therefore aids in retention. So retention of the denture in the objectives of impression making, we'll study about the how the saliva aids in the retention of denture. In patients with thick saliva, fovea should be uncovered because thick saliva and increased hydrostatic pressure will displace the denture. So in patients with thick saliva, fovea should be uncovered. Now we'll study about the relief areas. These are the areas which are resorbed under constant load or contain fragile structures. Therefore, they contain fragile structures, matlab nerves and vessels. So, therefore, denture should be designed such that the masticatory load is not concentrated over these areas, while as in supporting areas, the most of the load should be concentrated in the supporting areas because they are able to withstand the stress, because they are made of compact bone, they have thick mucosa, they are perpendicular to the load, so they will be able to absorb the loads. While the relief areas, the load they should be designed such that the masticatory load is not concentrated over these areas. So there are certain relief areas. So let's just get a brief about how we provide relief. Relief is provided by the spacer. Spacer is nothing just that modeling wax. You use it, so that is called as relief wax. Before making the impression, we'll form a custom tray. Yeah, we'll study about it. So relief is provided by the relief wax. So if wax is not available, we'll make relief holes. Okay, so relief is provided by the spacer. Now, what are the relief areas for maxilla? Incisive papilla. It is located on or labial to the ridge. It is a midline elevation of soft tissue behind central incisors over incisive foramen. So if these are the central incisors, इनके पीछे एक soft tissue elevation है, which is called as incisive papilla. It lies nearer to the ridge as resorption progresses, therefore indicates amount of resorption. So let's first know where incisive papilla is. It is a midline structure. It is located behind central incisors and in midline, and is an elevation of soft tissue, okay, over incisive foramen. If in case of resorption, it will be located nearer to the ridge, like we saw in the labial frenum. Then there we would do the vestibuloplasty. Here also, if it is located nearer to the ridge in case of resorption. Why is it a relief area, because it is the exit point of nasopalatine nerves and vessels. Because from this papilla, nasopalatine nerves and vessels exit, therefore should be relieved. Otherwise, denture will compress nerves and vessels, leading to necrosis of the distributing areas. Necrosis होगा of the areas which are supplied by the nasopalatine nerves and vessels. How the necrosis will occur? Because the denture will compress the areas, compress the nerves. So impingement of the incisive papilla will cause burning sensation, paresthesia and pain. What is paresthesia? It is an altered sensation, paresthesia. So impingement of this relief area will cause burning sensation, paresthesia and now mid-palatine suture. Yeah, mid-palatine raphe. We saw in the hard palate, anterior part was formed by the palatine process of the maxilla, which were merging in anteriorly in the median suture. So this is that suture. It extends from incisive papilla of to the distal end of the palate. It extends from the incisive papilla to the distal end of the palate. So this is the mid-palatine suture of raphe. The submucosa in mid-palatine suture is extremely thin, hence relief should be provided in part of the denture covering this suture. Wherever this area on this wherever this area is to be covered by the denture, we have to provide the relief prior. So this area is the most sensitive part of the palate to pressure. Bone is directly attached to the mucosa. So we know the mucosa, then there will be submucosa, then there will be bone. Since submucosa is very thin, extremely thin in this area, therefore bone will be directly attached to the mucosa. So इसका resorption का chances are more. So this was about the mid-palatine suture or raphe. Now coming on to the cuspid or canine eminence. It is a bony elevation on residual alveolar ridge formed after extraction of the canine. This is there only after the extraction of the canine. It is located between canine and first premolar, and relief is necessary to prevent pain and trauma to tissues beneath the denture. Now coming on to the fourth relief area, which is torus palatinus. Torus is a bony enlargement. It can be in maxilla and as well as mandible. In maxilla, it is called as torus palatinus and is located on the palate, while as in mandible, it is located on the lingual surface near the premolars and is called as torus mandibularis. Mandible का torus is torus mandibularis and maxilla का torus is torus palatinus. It is not always present. So, what is torus palatinus? It is an hard bony enlargement that occurs on the midline in the roof of palate. If this is the palate, it will be located midline in the roof of the palate. So, it is covered by thin layer of mucosa. It can be easily traumatized by the denture base, therefore relief should be provided by the relief wax. If it extends posteriorly to vibrating line, it may need to be surgically reduced to achieve posterior palatal seal and retention. So this is just a gist. This is the labial frenum, labial vestibule, buccal frenum, buccal vestibule, residual alveolar ridge. This is the maxillary tuberosity. These are the rugae, Phobia, Palatine. This is the anterior vibrating line. Why is it curved? Because of the posterior nasal spine. There is anterior nasal spine and posterior nasal spine. Anterior nasal spine is located anteriorly and posterior nasal spine. This is the reason for the curved or bow-shaped anterior vibrating line. So I hope you understood. Thank you.